So now I would like to invite Dr. Anand Rajendran sir. He'll be talking on interpretation of OCT, something which is very important irrespective of the specialty you practice.
So OCT is something that has taken the diagnostic world of retina by storm over the last maybe 1.5–2 decades, and it's really become quite like what CT and X-rays are for a physician. Okay, so are my slides up? Yeah. Okay. So with time comes, technology leaps, and this is how we used to see telephones in the 90s, and this is how we do now, and this is how we used to see computers in the 90s, and this is how we do now. And similarly, this is how we used to see OCT images around the late, the millennium, turn of the millennium, and this is how we do now. So there have been rapid advances indeed in OCT imaging. So we began with, in the mid-90s, late 90s, with the Stratus OCT, where we had about, a few thousand A scans per second. That's how slow it was. And then you see those gray dots, we moved from time domain OCTs to faster spectral domain OCTs, and most of us are using that still. And to the point that now we have what is known as swept source OCT, which are, as fast as about 100,000 A scans per second. So this is the original time domain OCT, where reflected light from a sample tissue matched with that of reference mirror, and you see this movement of this reference mirror allows acquisition of depth information. But because there's a moving mirror, moving part inside, it was pretty slow. And we then moved on to spectral domain OCT, which is much faster, simply because there's no moving components, and you get almost all the A scans at one shot. Yeah. And from there, recently, in the last few years, we have moved on to swept source OCT, where basically you have a swept wavelength tunable laser. Instead of only looking at one small slice of the output of a broadband source, naturally limits the signal to noise ratio. All of the light is now collapsed into a single wavelength, and that wavelength is swept across a range of different wavelengths, and this therefore increases the signal to noise ratio and can boost up the speed. So why is SD-OCT or spectral domain OCT helpful? With the old time domain OCTs, it measured less than 5% of the mapped area, and errors were propagated across, therefore, a large area. And if those lesions fell between these raster lines, you could miss them. Whereas with spectral domain OCT, as you see on the right side, that whole cube is mapped, and you get 100% of the area, apart from the fact that speed is accelerated 100 times. So this is how we see OCT images now. You see almost all the layers. In fact, they even split up layers out there, and it's virtually optical histology. You see the histological picture virtually simulating what you see on the OCT image. So these are spatial representations. So line scans, the routine ones that we get, are like the two faces of your Rubik's cube, vertical and horizontal. The on-fast is like the top of the Rubik's cube. That's the on-fast. And put everything together and you get a 3D image of the Rubik's cube as such. So these are representations. This is the surface of the retinal thickness ILM map, and this is how a normal map should look like. Macular edema is where there's a swollen blister in the middle, and it's color coded, so you see red and white on top. And epiretinal membrane is like a chewing gum on top in green, and diffuse atrophy is where you get a dimple and this thinning out. So this is the foveal microcosm, as I'd like to call it, and it simulates that central tower of your the foveal zone. So this is your RP Brooks area. Just to let you know, this is your interdigitation zone out there, okay, which is the tip of the photoreceptor. This is the outer segment, okay. And this is that conical area. So this, because all the photoreceptors are bunched in the foveal area, this is thick out here, and beyond this is your ellipsoid zone, okay. And this is at the junction of the outer segment and inner segment. And beyond this, next comes the myoid zone, which is the body of the inner segment. And beyond this is the external limiting membrane. And after that is what you get is the outer nuclear layer and the Henle's fiber layer. So this is, in short, a brief gist of the very central area, which is the most vision defining area, and this is the area that you need to look at to see if patients are losing vision early. So indications can be classified into, the vitreoretinal interface coming from top to bottom, where you can get pathologies like ERMs, vitreomacular attraction, subhyaloid hemorrhage, and we'll see examples of these. Nerve fiber layer, myopic traction, maculopathy, X-linked retinoschisis, plexiform layers, where you'll find pathology of diabetic and cystoid macular edema, photoreceptors, heredomacular degenerations, detachments in all layers, macular holes, and subretinal layers, CNVMs. You can reclassify this anatomy to explain, the same classification to explain the pathoanatomy, for example, macular hole, XLR, CSCR, CNVM, and look at reasons for doing surgery, macular edema, or not doing surgery, macular hole, macular TRD, VMT, similarly indicating futility of surgery in macular edema, HUL also. So coming to AMD, this is an occult CNVM. I think Rajendran and Uni before have described OCTA and FFA features of these. So with the type 1 CNVM, you have the RP elevated. As you can see here, the RP is elevated, there's subretinal fluid here, and there's neovascular material under the RP. And this is an example of a regression. So when anti-VEGF is given, this neovascular tissue just regresses, and you see that bump out there. On the other hand, this is an example of a classic CNVM where you have the neovascular material above the RP, as you can see here. And again, an example of a regression. Once you give anti-VEGF, you see that melts off and regresses there. The subretinal fluid a little bit, and the intraretinal fluid also goes away. An example of a RAP lesion. RAP has different stages. This is an ICG showing the hotspot with intraretinal neovascularization, and this is seen on the OCT here. These are old images, and this is stage 2, where the ICG shows intensification of this hotspot and serous PD hypofluorescence. On the OCT, you see this bump out there and the intraretinal fluid out here. And third stage is when the RAP lesion dips inside or under the RP. So ICG highlights the retinochoroidal anastomosis with intra and subretinal and choroidal networks here, and you can see this cascading neovascularization with the RC anastomosis. So this is another example of a RAP lesion where you have the disproportionate amount of hemorrhage on the fundus photo, hazily seen on the early and the late phase FFAs. And importantly, you see the RP here and this little clump of neovascularization emanating from the retinal circulation. On the OCTA, you see it better here, and this is the magnified view of the network. Another example where you see the RAP lesion, where right there, the elevated PED, the RAP lesion is diving down under the RP, and you see it on the OCTA here, the network, and post anti-VEGF, you see the intraretinal fluid and the subretinal fluid regressing, as well as the OCTA lesion getting wiped out. This is an example of AMD with a disciform scar. I'd like to direct your attention to what is now being called the outer retinal tubulations. These are giveaway signs of chronicity of lesion. Basically, defunct photoreceptors evaginate amongst themselves and they form pseudocysts. Okay, and you can see these not just in scarred lesions, you can see lesions without scars, which tells you, when you see these, it should tell you that this is a chronic lesion you're dealing with, and it might not benefit from so much from treatment. So these are hard drusen's of dry AMD. I'd like to direct your attention to these, this bumpy sawtooth kind of appearance. See, the RP is being elevated. Note that the RP is elevated. Why I'm telling you this is because contrast this with the next lesion, what I'm showing you, reticular pseudodrusen's, which is like a rash, like a yellow rash out there, pinpoint lesions, as opposed to the hard drusen's that you see here, which are a little bigger. But what you see here importantly on the OCT is you find lesions, these kind of sawtooth lesions above the RP. So these are actually subretinal drusenoid deposits. So these pseudodrusen's are above the RP. Okay, and now these are soft drusen's. So you see more dome-shaped lesions and little rounded lesions, and you can see that on the fundus photo here, as well as the multicolor image there. Geographic atrophy is an advanced form of dry degenerative AMD. This atrophy of the RP and the underlying choriocapillaris, so that because the choriocapillaris layer is no longer there, the larger bore choroidal vessels are seen through. And to be called dry AMD, geographic atrophy, you need to have at least 175 microns or more. So if somebody asks you in the exams, this is the number you have to quote. They're also known as areolar atrophy. This is an example. Again, you can see that clearly, the geographic atrophy on the multicolor image, as well as on the autofluorescence here and on the infrared image here. And you can see exactly this area, the RP is missing, the choriocapital is also thinned out, and there's a lot of shadowing. Okay. Polypoidal choroidal vasculopathy is another form of macular degeneration that we have come to understood a lot more in the last 1.5 2 decades. So you basically, as you can see on the polyps, and has been described again by Jatinder and Uni before, you see these polyps here, and you have this huge massive elevation of the dome-shaped elevation of the PED, and you have this intraretinal fluids, and see post-treatment you can see that settling down very well. So these are different types of PCV, notched PED. So this is a kind of a sign. When you see that, you know that you're most probably dealing with a PCV. This is because there's a polyp under that, probably pulling that PED down and creating a notch there. You have the steep PEDs, you have these hemorrhagic PEDs, the kind that I showed you earlier, serosanguinous, which means just mix of both blood and serous fluid, and there's the subretinal hyperreflectivity. You can get a cavitation, which is the cross-sectional lumen of a polyp right there. So all these are different OCT features of polypoidal choroidal vasculopathy. Another case where there's again thumb-shaped PD. It looks like a thumb stuck out there, and there's a lot of subretinal fluid, a bit of intraretinal fluid. Again, post-ilia, post-injection, you can see that settling down very well. This is another example of a massive submacular hemorrhage, and you can see again with tissue plasminogen activator and gas, you see that settling down, and then with ranibizumab it settles down further and it regresses completely. So we have seen two forms of macular degeneration, PCV and AMD. In PCV, the choroid is thicker. This is something which is very important, and there's a mode on the spectralis called the enhanced depth imaging, where you can see deeper. So you see this is much thicker than the choroid in AMD, and in fact in AMD it's called age-related choroidal atrophy, because there's choroidal thinning. So even if you have something which looks similar, look deeper, look at the choroid, and you'll find PCV has a thicker choroid more often than not, and AMD thin choroids. Acute CSR is another common disease. The serous elevation, the retina is elevated, and you'll find this fibrin under the RP, under the retina as well as over the RP. And this is the classic ink blot leak. Starts as a dot and then increases. Jatner also spoke about that. Another typical example of acute CSR where there's elevation. Look here at this RP. So this is little hyperreflective here, and there's a large large bore vessel called Pachy vessel out here. And this is the typical classic smokestack appearance that we come to associate with CSR. And this is subretinal fibrin out there. And with just a focal laser, it settles down very well. This is an atypical CSAR with the ink blot leak being distorted. Why is it distorted? The OCT gives you the answer, because there's subretinal fibrin tacking that undersurface of the retina to a leaking PD, and therefore there's distortion. This is a chronic CSR. Just to highlight that this is part of the pachychoroid spectrum, you can see these massive tube-like, choroidal vessels out there. And we just stress this patient, that subretinal fluid, which you saw earlier, right here, that goes away. So stress relief is a very important part of conservative management of CSCRs, and you see that little PED out here, and these big massive cavitary lesions which are called Pachy vessels, basically thick vessels. Pachy means thick. Another old favorite, this is a CSCR of a multi-pronged rip with the OCT at 3 different levels. Look right here, this corresponds to this one here, where there's a vacuolated subretinal fibrin deposit. So this is a vacuole or a space within, and that shows up here as an area of clearing. On the other hand, when you come lower, there's the area of the rip here. You see there's the discontinuity of the RP. So absence of RP, and therefore this shadowing pass-through of the light. And at the fovea here, below here, is a little bit of subfoveal detachment, which is why vision is fairly good, 612 for such a massive lesion. And when you did the angiogram, you see this is the leakage, multi-pronged leaks. It's like a white lizard, the tail being on fire, as well as extrafoveal leaks. So this is now moving to diabetic macular edema. You can get some massive edema at times, and this is called skytic edema. You see this entire structure is stretched, and this vertical, it's almost called vertical palisading. Different types are there. This is cystoid edema, which is fairly focal and like a cystoid balloon out there. And this is the same cystoid edema with a bit of subretinal fluid out here. And this is cystoid edema with diffuse subretinal fluid. You can also get a different kind called spongy edema. This is like a cake, like a sponge out there. Okay, it's diffused along the breadth of the thing, and this is spongy edema with subretinal fluid. So these are different morphological types of diabetic macular edema. Branch retinal vein occlusion, macular edema. The clue to diagnose a BRVO is one side will be thickened, the other side will be fairly flat. So you see the scan passing through this area. So this side is normal, and this is the macular BRVO right here, and this side is thickened. So when you see this, you should be able to say that this is a BRVO. Similarly, it regresses very well with anti-VEGF, and you see the regression. Similarly, CRVO, you have a mountainous edema, so it will be on both sides, and you can see that tomato ketchup kind of thing on the appearance on the infrared, and again regresses well with anti-VEGF. Another example of the same. Macular holes, we need to, OCT tells us a lot about pathogenesis, when to operate, when not to operate, how fast a hole could close, when ILM peeling is not critical, why vision did not improve. So this is the classification which has been put out first by Gass and Godric, gave us an OCT correlate, so you can read about it. So these are the different stages. So this is stage 2, where this is just lifted up, the flap is lifted up. This is the stage 3. I'll just finish in a couple of minutes with the operculum here, and this is a full thickness macular hole. So this is a stage 2 macular hole. You can see the pre-op 624, and then post-op improves. And this is stage 3 and post vitrectomy and ILM peeling. This is a macular hole with the regmatogenesis detachment and settled after vitrectomy and putting in oil. And this is a diabetic macular detachment. You can see the traction there and a stretch hole out there. And after vitrectomy and settling, removing the traction and putting in oil, you can see it settling there. This is trauma. So this is trauma. Here you can see that settled commotio retinae. You can see this scan taken here. You can see one part of it is atrophic. So this which a patient will definitely have poor vision. And this is vitreomacular traction, so which is pulling on the macula, and you can see different varieties with the outer lamellar hole out here, and with full thickness macular hole with epiretinal membranes, with tractional macular edema. And these are cases where you can operate and you should operate and you'll have good outcomes, whereas other where you have degeneration or scarring out there, these are cases where probably you won't have great results. Probably should not sing. I'll skip this kind of case. Am I out of time? Almost out of time. Okay, so this is a very interesting case which I quickly want to show you. In the left eye, the patient had a macular hole, went in for surgery. In the right eye, look what's happening. A traction is developing on in the fellow eye at the same time that the left eye is getting repaired after the ILM peeling vitrectomy, and you see that traction develops and that breaks off spontaneously. And a few months later, even though patient was advised surgery in December 2019, patient didn't want to take the other eye surgery so soon, and you see the spontaneous improvement. So just to show you an interesting case, an epiretinal membrane you can see right sitting on top like a cap out here, and resolution post-surgery. Inflammation, Koyanagi Harada, which Bala talked about. You can see the corrugated choroid. So this is important. When you see a corrugated choroid, you know there's something happening from the choroid, and that on the other eye you can see subretinal fluid also. And with just steroids, you can see the improvement, the anatomical restoration. A case of posterior scleritis with multifocal serous detachment, as you can see here. And this is interesting because you can see that the inflammation, the turbid subretinal fluid, and this little tack pulling up the PED. So when you see a conical PED like this, know that this is not CSCR. This is inflammation. Conical PEDs can happen largely only in inflammation, and it just melts off with steroids. Another example of an APMPE, and you can see here, this is an interesting finding where you find just the outer retina being split and the edema right there, intraretinal edema, and this is called a bacillary layer detachment sign. A dome-shaped maculopathy is something you get in myopes, and especially if you have the scans running in the vertical side. A myopic CNVM, I'll run past this. Same thing, you can see a very thin choroid. I like to direct attention to this very thin choroid here in the myopes, and the CNVM melts off with anti-VEGF injection. Some examples of macular schisis, X-linked retinoschisis. I mean, this is myopic tractional maculopathy. You see the dome. When you see on the OCT a dome like this, you know you're dealing with a myopic case because of anteroposterior traction. The macula is split, the retina is pulled up. and you see this kind of example. This is an example at the foveal. You can see there's a CNVM and a different levels.
Anand,
You can see how it's
running out of time. They've stopped the timer. Some problem.
Okay, okay.
Can we
Okay.
just conclude?
So I'll just quickly just conclude with telling you that OCT is a great non-invasive diagnostic tool, elucidates pathogenesis, points out surgical indications, prognosis, helps follow for treatment cases, and shows up poor cases of recovery, and explains unusual disease presentations. Thank you.